Hello, everyone. Thank you for joining today's session, the impact of copay accumulators and CMS best price rule on manufacturer programs. This webinar is sponsored by TrialCard. TrialCard Incorporated provides patient affordability, medication access and adherence, patient support, and clinical trial services on behalf of pharmaceutical manufacturers. Founded in 2000, TrialCard has connected nearly 33 million patients with over 15 billion in branded drug savings to date. The company is headquartered in Morrisville, North Carolina. I'm Sean Edwards from World Congress. I'll be introducing our webinar today. Just a couple of announcements before we start. I'd like to explain how we're handling questions. Due to the number of attendees, participant lines are muted. However, if you'd like to submit a question for our speaker, please do so using the Q&A feature that you see at the bottom of your screen. We'll answer all questions that we have time to address during our session today. Please feel free to contact our presenter if you have any additional questions that we can't get to today. And finally, please note the webinar is recorded. You'll receive an email with a link to the video so that you can view it again. And now I'm going to turn things over to our speaker for today. Jason Zemcik is the Senior Director of Product Management at TrialCard. Jason, welcome. Thanks for being here.
Absolutely. Thank you, Sean. Thank you to the entire team at World Congress. As always, I say it often, but you are a pleasure to work with, and we certainly appreciate the opportunity to discuss this topic. It's just one of the many critical issues that are top of mind to pharmaceutical manufacturers recently around policy developments impacting their programs. So our hope today, as always, is that you'll get a lot of useful information that helps you and your team make your assessment of this topic and ultimately map out your strategy and your plan for how to address it. So that said, we'll get right into it. We have an hour. I know there's a lot of different angles to this, so hopefully we can deliver as much useful information as possible. Here's a quick overview of everything we're going to discuss today. A lot of these could be their own conversations by themselves, so we'll try to hit some of the high points and just give you important things for consideration. We're going to do a very quick background just on how accumulators operate. I think by now, pretty much everyone's familiar with that. But just to level set, I think it could be helpful. And then talk about some of the very recent market developments that are driving the trends around accumulator use. We'll get into the overview of Medicaid best price and then ultimately leading us to the final rule, the CMS rule that was recently finalized, and how that is going to impact manufacturer programs, and talk a little bit about how you can form your own assessment of how it would have impact specific to your brand and to your program. Get into some approaches to solving this. There are a couple different ways that are starting to emerge that we've learned in our conversations with manufacturers and that we're assisting them with. And then ultimately wrap up with a planning timeline and also a little bit of discussion just around some of the policy things to be looking for as we factor in the impact of a new administration and the political climate and landscape on drug pricing and manufacturer programs. So certainly a lot to get to. Obviously, we'll save some time at the end for questions. But again, definitely a lot of information to cover here. So let's begin. As you see here, this rule and the developments and the things that it involves kind of sit right in the middle there of that government and legal and market and payer risk classification. So when we think about the risks that manufacturer assistance programs face, obviously they come from a variety of sources. And as you can see there, there's no shortage of things that could cause disruption to manufacturer programs and that you have to contend with and always plan for. And so this one kind of just bridges the intersection between the government and the policy side, and then obviously some market and payer tactics, which we'll talk a little bit about more later on in the presentation. As I mentioned earlier, just a real brief overview, refresher on accumulators. I think by now, pretty much everyone in this space is familiar with this topic, how accumulators operate. They've been around for a number of years. But just in the event that anyone needs a refresher, the root of the issue is that in an accumulator scenario, a patient's health plan is not counting the benefit of any manufacturer assistance funds towards that patient's progress toward meeting their deductible. So as you see down there at the bottom of the graphic, the red arrow, step number 7 in this process, how this works is in most cases, the PBM, the specialty pharmacy, is going to be reporting data on the use of manufacturer coupon programs back to the PBM. And then that's what facilitates the operation of these programs. And then ultimately, when the patient's health plan uses that data to reconcile and to determine how they account for or don't account for, in this case, the benefit of these manufacturer assistance funds. So obviously it creates problems for a number of stakeholders. For the patient, what it results in is a scenario where they could very well exhaust the benefit of the copay program. Most programs will have an annual benefit limit, and they run out of copay assistance, but have not made any progress toward meeting their deductible. So they're faced with a fairly high out-of-pocket cost that can ultimately lead to abandonment of therapy for a number of patients. And for the pharmaceutical manufacturers that are offering these programs, obviously it causes a significant increase in their reimbursement spend because rather than a patient moving through their deductible period and copay assistance accomplishing what it's designed to do, that you continue subsidizing and subsidizing and subsidizing that patient because they're never reaching, their deductible. So this slide, I've always found this graphic very, very useful. I'm sure a lot of you are familiar with it. It comes from drug channels. So credit to Dr. Fine, who obviously imparts a tremendous amount of knowledge and wisdom on all of us that we're very appreciative of. And I use this often. It just shows some of the market developments, specifically around the vertical integration of specialty pharmacies, PBMs, and health plans, and how it facilitates the operation of these types of programs through those relationships, making that data sharing a lot easier just for these types of programs to be more easily carried out due to the ability for each of these entities to have access to that information. So moving on, a brief overview of Medicaid best price. And one of the questions we get often around this rule and everyone trying to understand, why is this such a big deal? And specifically, people will ask, what does a Medicaid pricing rule have to do with manufacturer copay assistance? Obviously, government-insured patients can't use copay assistance. So how do these two topics intersect? So Medicaid best price, obviously, it could be, and there are several presentations, it could be its own presentation in itself. But just as it applies to this situation, the basics are that pharmaceutical manufacturers have to offer state Medicaid programs the best available price that they offer to any other purchaser. So when you factor in and you look at any commercial rebates or other discounts or price concessions, they have to match that price to all the state Medicaid programs. And the rebate amount, it's the greater of either 23.1% or whatever the highest rebate is in market. And that can we'll get into when we dive deeper into some of the assessment and analysis here. That's where that can factor into play. Now, there are certain exclusions that apply, and that also has an impact on this rule, and it gets to the root of the issue that is caused by this rule. But in a nutshell, that's the situation with Medicaid best price, just simply the fact that manufacturers have to offer that to all of the state Medicaid programs. So moving into this rule and why it is problematic for copay programs, and this really ties it all together. So the rule states that pharmaceutical manufacturers must ensure that the benefit of their assistance programs are provided entirely to the consumer in order to be excluded from best price. So as I mentioned earlier, when you look at other commercial rebates, other discounts, price concessions, things that can be excluded that do not have to be factored into that, copay assistance, in order to meet that qualification for exclusion, it must be given only to the benefit of the patient or the consumer. And so in an accumulator scenario, that obviously is not taking place. As we described earlier, the patient is not getting credit for those funds toward their deductible. However, the health plan is realizing that savings, they're reducing their costs, their prescription drug spend. So that situation would then cause the pharmaceutical manufacturer to have to include the value of their copay assistance among their other rebates and price concessions. This rule, and we'll get into a timeline later on in the presentation, but it came out over this past summer. It was introduced at the end of June. There was a public comment period that lasted into July. And then it was ultimately finalized right before the holidays, the last week of December, published in the Federal Register. These provisions specific to what I just mentioned around how accumulator scenarios affect copay assistance goes into effect in 2023. So CMS noted in the rule, it's actually part of a broader pricing rule that becomes effective in 2022. However, CMS specifically noted that in order to allow the industry time to react, allow manufacturers time to adjust their programs accordingly, they were delaying implementation of this specific provision until 2023. So as you can see there in the bottom bullet, this creates a couple of challenges for pharmaceutical manufacturers, and they're all rooted in the fact that the obligation to address how the benefit of their copay assistance programs is accounted for falls on them, despite the fact that the manufacturers don't have visibility into or control over how insurers ultimately account for this benefit. So that's where it becomes extremely difficult. And also when you layer in the fact that at present time, and we'll get into kind of how this will change over the course of the coming years, but at present time, there really isn't a uniform disclosure standard that health plans have to abide by around use of accumulators. As we have talked about in previous presentations, some health plans do use these accumulator adjustments, others do not. And so on a patient-by-patient basis, the pharmaceutical manufacturer really does not have a way to know at the point of claim adjudication if a patient is in a health plan that uses an accumulator adjustment, and therefore the patient won't be getting credit for these funds. So that's really the root of the issues created by this rule, was just the fact that the manufacturer will become accountable for these despite a very reduced ability, or even in some cases inability to control them. So this leads us to our first polling question. We always like to see how our attendees look at this. So interested in hearing what everyone feels is the most problematic element of this rule. Now, I don't doubt that there may be a lot of people that answer all three of these things. So just curious if you could choose the one that stands out to you the most. Interested to see how everyone feels about the issues and the problems that this creates for manufacturers. I think we have a few more seconds, and Sean, whenever we're ready. All right, so it looks as if I'm seeing there it was a very close one, but it looks as if we have 40% lack of manufacturer control over how PBMs and health plans account for copay offer benefit. That's not surprising. A close second, inability for manufacturers to know whether a patient is in a plan using accumulators. So that's interesting. And then third, of course, unclear definition around how CMS will monitor and enforce compliance. So those are two very interesting points, obviously, because the first one, the one that got the most votes, is kind of it directly deals with the main issue raised. And then the second one, which is very close behind, it addresses the potential for manufacturers to operate their programs in a way that excludes patients who would be impacted by this, but there's just simply not a good way for them to really know that, to make that exclusion. So that's not surprising that got a lot of votes as well. So as we move on, and this is the stage that so many pharmaceutical manufacturers are at the present time. We've had dozens of conversations around this with our clients. Just in the time since we've returned, kind of everyone's gotten back to work after the holidays, and this when we really saw the pickup after the rule had been finalized and the timetable had been set, so to speak. The clock was running. We see pharmaceutical manufacturers kind of forming their teams, forming their task force, if you will, to do their assessment and really understand. So we're having a lot of conversations around this area right here. And so I think this graphic helps to really visualize the different ways it has to be examined. So obviously we just kind of wrapped up around the basics of what does the rule say. And it's obviously a several 100-page document, so trying to distill that down and determine what all it does mean for copay assistance programs. And then the middle one, the middle section here, we're going to spend some more time on, because this is critically important at the start of your assessment process. And that's figuring out truly how it will impact your program. And what I mean by that is everyone understands conceptually how this can affect copay, but applying that to your specific brand, your program, understanding all the economics of your program around what the value of your copay offer is and what you're currently paying in rebates, to really get a good sense of how it will impact you in that particular scenario. And then finally, the bottom section is what you ultimately arrive at from that assessment in the middle there. What's the best way to address it? And that's with your patient services, your market access teams that are likely dealing directly with your copay program provider to come up with the solutions. And if you make program adjustments, what those involve and how they're carried out. So this slide talks about what we were referring to in the middle section there, and quantifying the impact of the rule. And this is really, I kind of describe it when we talk to clients. It's crunching the numbers and doing the math. So you want to take a look at, for your brand, what is your cost? Where is your brand in its life cycle? What type of rebating agreements do you have? Are you negotiating with payers? Some brands may not be, some brands may be very heavily rebated. What does that picture ultimately look like? And then layer in what does your copay, what are the economics of your copay offer? What's your annual benefit? What type of utilization are you seeing of the program? What's your average claim value? Just really doing all of that analysis to understand, if you were to factor in the impact of copay assistance, what would that really mean in terms of a final, economic impact to best price? And then also kind of looking out a few years at your contracts. A lot of times payer contracts will be negotiated as multi-year agreements. And so kind of understanding what's on the horizon, when your current agreements expire, and what your leverage is in terms of negotiating and going back and renegotiating, or the next agreement. All of those things that just require a combined cross-functional task force team effort to understand the assessment. I think a lot of manufacturers are kind of starting to realize that that's necessary. As we talk to several, that's started with a number of companies, but I think others are still in the process of putting together that team to even figure out who's going to be involved in this project and in what capacity. And that leads us to our next polling question. So interested in understanding how you envision pharmaceutical manufacturers most likely addressing the issues caused by this rule. There's a number of ways, a number of things that could be done and that we hear talked about. But interested again to hear from the audience if there's one particular course of action that everyone feels may be more likely than others. All right, and it looks as if we have a clear favorite at this point. And again, not surprising. If I had to say, I would say probably the majority of the conversations we have with pharmaceutical manufacturers, it's probably centered around this angle. Operationally redesigning programs to deliver benefits in a way that complies with the rule. That came in first with 65%. Second and third, it was essentially a tie for second and third with 17 and 18%. Respectively. 18% we had renegotiate rebate agreements with PBMs to attempt to combat the use of accumulators, which there's an interesting point on that we'll get to in a few slides later in the presentation. And then 17% reduce the benefit of or discontinue copay programs altogether to not incur best price obligation. And that has obviously its pros and cons and considerations there as well. But it is not surprising, and that lines up with the conversations we've had, that the majority of the focus here seems to be around program redesign. So that's a good lead into this slide, which hopefully helps visualize each of these different approaches. So we'll start off with just go from top to bottom, and the first two are actually the two that kind of were neck and neck on the last slide. So we'll save the one that got the majority of votes for last and spend the most time on it. But the analytic approach is essentially what I talked about earlier. As you crunch the numbers, you determine what your best price impact will be, and then just seeing what the offer value, at what level essentially of offer value benefit your copay assistance program will cause you to incur an additional best price impact, and then simply reducing your benefit to not reach that level. That's obviously the least at least evasive way to address this, I believe, because you're not making any operational redesigns. You're not changing anything with how the patients interact with your program. But obviously, the significant downside to this is that you are going to cause some level of patient attrition. Patients that have claims that are on the higher end of your benefit range, you're going to cause them to not be able to use the program, and that's a significant consideration in a lot of cases. One that brands are not willing to go to. We talk to a lot of manufacturers, and there are some that are kind of taking this approach. But again, I think it all gets into the economics of your product, where you're at in your life cycle, and the competition in your therapeutic class. We've had many clients that simply say, we want no patient attrition. We don't want to go a route to try and solve this in a way that's going to cause some patients to fall off of the program, which is understandable. But that's the crux of the analytic method. The negotiation method in the center there, and this, as I mentioned, interesting point on this is that third bullet there. In the text of the final rule, so much is made of the obligations that CMS puts on the manufacturers and how they have to deliver their program benefits in certain ways. The rule also does note, and I quoted the exact line there, it says CMS we have the expectation that PBMs will work with manufacturers to provide this information. And what they mean by this information, if you read the preceding sentences, it talks about how manufacturer assistance is accounted for if accumulators are used in the plan benefit design and those types of things. So there is a notion of that by CMS in the rule. Now I note here, I say, it remains to be seen, and I'm personally very interested to see how this actually plays out in practice. To what extent will PBMs comply with this and furnish that type of information, or make it available, or help pharmaceutical manufacturers understand in which cases patients are and are not going to be impacted. And so obviously the other side of this coin then is that the manufacturers would be proposing different rebate terms based on whether a patient is, whether a plan does or does not impose accumulator adjustments. And I had it said to me in a client call just last week. We had a pharmaceutical manufacturer that said, it's not uncommon for PBMs to come back to the manufacturer and seek to renegotiate agreements. So it would essentially be the same thing, just the pharmaceutical manufacturer initiating that discussion and saying we want to propose different rebate terms based on accumulator use or lack thereof. The final section, where everyone seems to be focusing, is on actually redesigning your program. And this is one that CMS does mention this in the text of the final rule. Delivering benefit in a way that ensures that it only goes to the patient. So really, where this ends up, and for pharmaceutical manufacturers to be able to concretely say that with confidence that they know they're only providing a benefit to the patient, it essentially nets out at a rebate. The thing that kind of causes just consternation and angst within the industry and on the manufacturer side is just this idea of, and it's well-founded, that this approach seems to be in an industry that is hungry for innovation and trying to advance and improve and make things more efficient. This seems to be taking a step backward. I had one client jokingly say, this is like going back to 1996 in the days of mailing in receipts and getting a rebate. And as I note there in one of the bullets, you can have some technological solutions both around patient submission and reimbursement that can alleviate some of that. But the fundamental concept does appear to go that way. But when you think of it and think it through operationally, essentially what would happen is that after the patient's primary insurance makes their contribution to the claim, the patient would then have to, in some way, and it invites its own set of problems and considerations to solve, but the patient would have to make a payment to the pharmacy to complete their transaction, complete the claim, and then ultimately submit a receipt, submit that documentation to the manufacturer program to get reimbursed if the manufacturer chooses to provide that assistance, and then therefore the manufacturer knows they're only providing that benefit to the patient. Again, a whole host of considerations around that, just not only operationally, but from a legal and compliance standpoint, and then just ability to control it and risks and controls. It's kind of going into a different path. When you look at the Copay card, one of the benefits of copay cards operating through the pharmacy claim system is the fact that it's probably the most efficient way to deliver cost sharing assistance because there's a uniform standard of processing. The patient really isn't involved in that submission process and reimbursement process. It all happens through the pharmacy claim. So now you're asking the patient to be much more actively involved, which drives the need for you to be very deliberate and descriptive in your communication and how you explain everything to them. So just a lot of things that need to be considered if you are going down that path of trying to design your program in that way. So time for our final polling question, and this is a select all that apply. So what steps has your organization taken so far to address the rule? First one, obviously engaging other sources of knowledge, consultants, counsel, external advisory sources, and this includes having conversations with your copay provider, copay program provider about this. Second option, obviously establishing an internal task group to do the types of assessment we mentioned earlier. And then finally, which we'll touch on a little bit, advocacy work, trying to ultimately attack the root issue, which is the rule itself. So curious to see what all is being done by the majority of the audience. All right, so let's see. Again, we have another close one here, which is it's good to see high percentages on multiple responses. So these are all things that ultimately we would recommend getting involved with. And the top response, establishing internal task groups to evaluate impact. Again, not surprising whatsoever. I went through last week as I was preparing for this, and we've had in the neighborhood of 4 or 5 dozen different client conversations just about this topic since January 1st. So that's not surprising at all, as each time we talk to a manufacturer, one of the common themes that comes out of those conversations is we've assembled our team or we're in the process of assembling our team. So it's good that that's happening, and not surprising that is the top response. The second one, also, again, it's good to see that this is happening. Engaging consultants, counsel. A lot of manufacturers have gone not only to their general counsel or their legal teams, but also engaged outside counsel or other policy, consulting firms, areas of expertise, to really get a good understanding of not just the rule, but different solution options and understanding if you are meeting the intent of the rule, and also assessing your own level of comfort with different solution options, because that's another key theme that has come out in the early going so far. The fact, one manufacturer may have a very different read on a particular type of solution, especially when you get into rebating patients and direct-to-patient reimbursement. One manufacturer may look at that very differently than another, and a lot of times what we'll find is that they're going through multiple channels to try to form their assessment and get multiple opinions on those types of things. Finally, advocacy work. This is something that it's definitely the long range game, and not just addressing this rule specifically, but accumulators in general, and kind of all of the just policy topics around manufacturer assistance, which we won't spend a lot of time in this session getting into, but I absolutely think it's important because, as I said earlier, when you address specific symptoms, as we're kind of largely focused on here, you don't want to ignore the actual cause of the issues itself. And there's this kind of ongoing, back and forth within the industry around copay accumulators and copay cards in general, manufacturer coupons, what the appropriate place for them is and how they impact drug pricing. And, these are the areas where you do need, as a manufacturer, to engage, your relationships with industry trade organizations, your government affairs teams that deal with legislative channels, and all of the different kind of external advocacy sources that you work with. So getting into a planning timeline. Now, suffice it to say, this is far from a one-size-fits-all. This is not going to perfectly match what every pharmaceutical manufacturer, and even within the same company, what every brand or franchise or business unit, how they're going to approach this. But obviously, it's meant to provide kind of some guidance on key milestones and areas, that you really want to make sure you don't overlook and make sure you address. So as you see here, the light blue shaded area, we're in the first half of 2021. And as I said, if you haven't started already, you need to definitely be assembling your task force and conducting those internal assessments, because that's what's really going to enable you to make an educated and well supported decision on how you want to address this, versus just going off kind of the understanding the concept and kind of the anecdotal impact potential. As we move into the second half of this year, this is where, if you do choose, and it looks from the polling responses that this is, at least at this point, this is where a lot are thinking. This is where you want to begin going into those program design discussions. And, you need to lean heavily on your copay program provider to really talk through all of the different options around that. Specifically, if you're going into any type of a direct reimbursement, a patient rebate type scenario, again, not to take up the entire session just talking about that and the operational aspect, but it's absolutely critical. Everything from what your reimbursement methods are to how they're delivered, and then very, very critical is understanding how you inform the patient of that, and how that factors into your program design. The other element there, which it's kind of not of the same course of action here, but if you do choose to go the route of trying to renegotiate agreements with PBMs, this would obviously be the time to start. Again, we had one manufacturer mentioned to us in a conversation last week, not specific just to this, but in general with this topic, said, 2023 is like next week. It seems, we have almost 2 years, but when you really think about the planning horizon, and especially in larger organizations and so many moving parts and future planning, it's going to come quick. So now is definitely the time to begin all of these activities. As we get into the start of next year, this is where you want to be running actual pilot programs if you choose to redesign your offer, how you deliver it. Because the thing here is you don't want to switch your entire program over to a new model all at once. Likely what is going to yield the best results is to take a subsection of your program, take a cohort of patients and test it out and kind of learn, do some learning, understand how things really work, and then make that decision to roll this type of new program out across the entire patient population. And then, as I have there on the bottom of the half one of 2022, determine what your implementation plan is. And this is where you're really mapping out ultimately how you're going to put all these pieces in play. And then finally, as we're coming into the end of 2022, this is really where you are in the zone. You're preparing to operationalize new solutions. And the key elements I want to focus on there are just solidifying your support infrastructure. So much focus and attention goes into the program itself and the design and the business rules and the tools and the reimbursement mechanisms. But a critical element to this, and one that you don't want to overlook, certainly, is your support infrastructure. And what that is all of your patient messaging, your patient talking points, provider education, helping everyone involved in this process understand that there are going to be differences with the program, and it's going to change, and here's how you interact with the new program. Everything from making sure patients understand why this needs to happen. I say this often in conversations, but I think all of us, if we didn't work in this business, we probably would have a hard time understanding a lot of these topics. So I try to put myself in the shoes of just the average patient, average consumer of healthcare. I'm not going to understand what's going on with a government rule and my insurance, and why the copay card that I've used for however long I can't continue to use. So you have to be very well thought out in terms of how you message patients, how you inform them. And then ultimately you will encounter questions and escalations, and just especially in the early days of a new program type. So making sure that you have a support system to be able to handle those, to be able to respond to those, to have accurate information. That is definitely a very key component of this. And then at the bottom, of course, I have it as it's an ongoing effort. And I think everyone probably realizes this, the advocacy work just to address this rule and accumulators in general. So one final aspect of this that I want to touch on, and it does come up, we get questions about this, And this further complicates matters. Is, what impact is there an impact from the recent change? We have a new administration, we have change in control of Congress. What impact does the political landscape play on the future potential of this rule? The short answer is it depends, which I know that's everyone always wants an answer, but joking aside, I think we absolutely have to pay attention to what happens here. So if everyone's familiar, upon inauguration, President Biden signed a series of executive orders, and one of those was a regulatory freeze and review. So it states, where this rule is impacted is under the category of rules that have been finalized and published in the Federal Register, but not yet become effective. So that's where this rule obviously falls under that category. The order recommended considering a 60-day review period for rules that meet those criteria. So we're in that 60-day review period right now. What comes of that remains to be seen. It could be that nothing comes of it and the rule stays in effect as is, and it'll go into effect as written in 2023. The memo does, however, suggest considering opening up another public comment period for these rules. Now, as we mentioned, there was one on this rule back over the summer. And so whether CMS chooses to initiate another public comment period, we don't know. I personally think it may be less likely than it would, but we honestly don't know. But that's part of it. And then just ultimately seeing between now and 2023 is obviously, we talked about that will come quick. But at the same time, a lot could happen. And I think, everyone always kind of makes the analogy, if we had a crystal ball, we don't, but I think we have to just kind of keep a close eye on that bottom bullet there, the broader topic of how drug pricing will be handled in the years ahead under a new administration, because there are ultimately kind of a number of downstream effects that play into both this topic and then also how manufacturer assistance programs are handled. And a couple things that are on the horizon, and also, kind of in this period of remains to be seen what will ultimately become of them, are a number of other regulations that were finalized towards the end of 2020, kind of in the closing months of the previous administration. And specifically, there was one around price transparency that also has some provisions that go into effect in 2023, specifically requiring disclosure of accumulator use by health plans. And this is actually something I don't know for sure, but I brought this up in another discussion, and it kind of was, there were a few other people within the industry that kind of had the same thought. Potentially the intent of the administration there was to align these two things. Because when the disclosure requirement around accumulators becomes effective and that information becomes known, if you think back to the first polling question and what do you see as one of the most problematic elements, there were a lot that answered, and one of the biggest problems is just simply the fact that manufacturers don't have that visibility into whether a patient is impacted. So when that does become available, that could then drive an ability for manufacturers to establish their enrollment criteria around the program so that known accumulator impacted patients are excluded from copay assistance. And kind of thinking similar to the dynamic that occurs around all of the government exclusion and anti-kickback topics, being able to exclude patients that have government-sponsored insurance. Now, a couple of considerations around that, and I think one is that as we understand it, this information may only be made available to plan members. So as opposed to the general public having access to this information, or for example, a copay program provider being able to do a check on a patient, it would function in the way that the patient has a lookup tool. Their plan provides a lookup tool, or their plan, ultimately the CMS in the rule they mention about third-party providers within the industry building tools based on available data. But the patient could look up and see if their plan has an accumulator adjustment in place. And then upon enrollment for copay, that would become a screening criteria. And again, similar to the government exclusion question that is on most copay program enrollments, there could be a question around, does your health plan impose accumulator adjustments, or does your health plan count the value of manufacturer assistance toward your deductible? So there's the possibility for that to layer in. But again, as I think everyone can probably see just from that brief example there, that brief scenario discussion, that would be challenging as well, because so much of this, again, it's just rooted in being able to make it understood in common terms and common language by someone who's simply trying to enroll in a program to help pay for the cost of their medication. So there'll be some challenges there, but I think the bigger idea and bigger takeaway from this is just simply that we have to keep an eye on what will come of the future of so many of these policy matters that were finalized under the previous administration. As far as this rule, again, it's not rooted in anything other than my own personal observation of the industry and just kind of seeing in the space and policy matters. I think it's probably less likely that this rule would get done away with or withdrawn. And the reason I say that, and again, it's just my own speculation around this, is the fact that the root mechanism of this rule, Copay accumulators themselves, those have been positioned, and CMS has very frequently, if you look over the course of years of the notice and benefit and payment parameters in recent years, CMS has described accumulators as a way to address rising prescription drug prices. Now, there are a multitude of arguments and points that can be made on both sides of that topic, and I think we all realize that. And there are entire sessions and discussions around that itself, and that's an ongoing debate that I think will continue among our industry and within the government and all that. That is the underlying assumption that accumulators are a way to address the rising cost of drug prices. I think that message, and as you see, as we just went through an election cycle, that message plays well really with any audience, with the general public, with legislators, regardless of what side of the political spectrum anyone falls on or what party holds office. I think if we look back, addressing prescription drug prices has been, kind of a key objective of pretty much every political administration for a number of years. And I don't think that would change. So for that reason, I actually feel as if this rule is probably likely to be one of the policies from the previous administration that may remain intact. Again, that's just simply my own assessment of it. But I think, kind of when you break it down into the elements and look at what is trying to be accomplished and what the intent is, I think that's a logical conclusion to arrive at. So where that ultimately nets out for pharmaceutical manufacturers is just simply that you really have to walk that fine line and appropriately balance planning for the rule to go into effect with the fact that there could be a modification, there could be an ultimate withdrawal. Again, we say that may not be likely, but you really just have to plan for the future, but also not invest or commit so many resources that if the rule ends up changing or the entire situation changes, that investment is for naught. So it does set up a challenge, and it's something that you just have to appropriately manage and make sure that you are keeping abreast of all the developments around. So that concludes all of the prepared information we have. We do have a number of minutes left. So I want to first say thank you again to everyone for attending, and also thank you to the team at World Congress. And with that, we have time to take some questions. So happy to hear what questions may be out there.
Great, thanks, Jason. First question, how might some of the recent merger and acquisition activity in the marketplace, specifically with claims processors, affect this topic?
Very, very good question. And we've been getting asked about that a lot. And so I think, people are probably well aware, and you've seen in the news, there have been some M&A events in the marketplace where some claims processors have been purchased by PBMs. And I think really where that ends up at is the fact that it could potentially create an easier pathway to facilitate operation of these accumulator type programs. Now, within that, you really have to kind of make your own assessment, form your own opinion, because I think there will be probably different business units put in place around this, different firewalls, if you will, to prevent that. And what I mean, probably I should have explained it better, is just the fact that direct relationship, that ownership of a claims processor being owned by a PBM would just make it easier for that data to be shared and transmitted. And ultimately, that's how accumulator adjustments operate, is by data getting, use of copay cards, that information getting to the PBM and ultimately, to where the insurer can do that accounting. So, direct ownership is going to make that easier. But as I said, there's probably going to be some firewalls put in place. But at the same time, I think if you read some of the press releases around recent events, there's very much talk about how these new relationships are created to take advantage of the availability of the vast array of data to drive further value in healthcare and all the kind of things that you hear, which could ultimately mean reducing costs for health plans. So I think it's just something that you have to form an assessment of, but be cautious of. It's by no means going to be a immediate detriment, or an absolute detriment probably is a better way to say it. But it also very well could pose risk to a copay program. And so, where it would end up as it relates to this topic is the fact that accumulator imposition would be easier, and therefore the triggering event to incur this best price obligation. So yeah, definitely something that is happening in the market. But I think if you're depending on who you partner with to operate your copay program, it's something that absolutely I think you need to be aware of.
Got it. Now, for manufacturers seeking to design a new copay program for their product, let's say there's not currently a copay program available. For those manufacturers who don't have a strong understanding of the level of utilization of a copay card program, what's your recommendation for how they might be able to assess the likely impact to best price calculation?
That's a good question. So generally, when we work with a client who is standing up a new program, they may not have that background or familiarity. We can run some analog assessments, and I'm sure most of the copay program providers will do something like this. But we would look at analogous brands and that do have copay offers and understand ones that are in our portfolio. We obviously have that data, and we can do some modeling off of. But that would be my recommendation on where to start is, find a brand that is closely analogous to yours, and then have an assessment done through your copay program provider who you've chosen to run the program. Have them do some analysis, do some modeling around similar programs to try to understand utilization. So those are the direct data insights. And then I think you also have to layer in kind of some of the intangible factors, things that you may not necessarily be able to directly quantify out of data, but things like how you plan to distribute your offer. What are the dynamics around your therapeutic class, and what does the competition look like? Those are all things that are also going to impact your utilization, that are maybe less succinct in terms of being able to get hard data to quantify. So that's how I would approach it. Is ultimately step one would probably be having that analysis done based on similar programs.
Got it. Thank you. How can the CMS best price rule potentially impact maximizer programs if the patient benefit is not 100% going towards the patient?
Good question. And this topic of maximizers, it always comes up. How do maximizers play into this? So the short answer is that it would impact those as well. So maximizers, similar to accumulators, and under a copay maximizer, the patient does not get credit for the value of the manufacturer assistance funds toward their out-of-pocket. The difference is simply that a maximizer, in most cases, it's designed to spread the value of that manufacturer offer out over the course of a year. And in a lot of cases, there are some other designs, but kind of the fundamental concept there is that you're not going to cause the patient to get to that copay surprise, if you will, or copay cliff, what we talked about earlier, where they exhaust the benefit but haven't met their deductible. But separate conversation on just all the differences between accumulators and maximizers. But in short, under a maximizer, the patient is also not getting credit, and therefore that would incur that same best price obligation because the benefit of the offer is being realized by a party other than the patient, other than the consumer.
Got it. To your knowledge, what's the typical threshold of, let's say, WAC versus RX cost that triggers copay accumulators to kick in, or are copay accumulators applied to a specific class of medications?
It varies. So we don't have it. It really is across the board, and I don't say that just to kind of dodge the question. We truly we've seen, depending on the brand and the value of the copay offer and a number of other factors, it can be wildly different from one program to another. A couple things that are going to influence the imposition of accumulators. It's really, when you think of it in terms of what the purpose is, and that is to help the health plan and the plan sponsor reduce their costs. The products and the copay programs that create the most ideal opportunity for that are ones where you have high volume and high cost. That's going to give the biggest opportunity for savings. So that's always the starting point that we look at with a product. And when we're talking to manufacturers, we say, what is your volume? And then what's the benefit of your copay offer? If you have, and it's not uncommon nowadays to see copay programs where, the annual benefit can be in the several, tens of thousands of dollars annually. Those are going to be your programs that are going to be higher accumulator targets, because again, that's where the plan can realize more savings. But as far as a hard and fast rule, we haven't seen a whole lot around that. Now we will get all the time, we have brands contact us, obviously current clients, and then even others that are just looking for other, just information and kind of checking things out. And, we'll do some basic analysis, kind of more specific to therapeutic classes, because to answer the other part of that question, again, we see impact across a number of therapeutic classes. It is slightly higher in some than others. But we can do that kind of analysis, and any, your copay program provider, if you're not working with TrialCard, I'm sure that, you're doing that, or you could do it. So those are some of the key things. But to get back to the main point, it's really, I think the two things that I would say are the biggest drivers are cost and volume.
Got it. Another question, Jason. Understanding the lack of visibility into how the copay benefit may be applied, what are your thoughts on the impact of programs that are retail versus specialty pharmacy?
So that's an interesting question, and it does come up a lot. And in present day, we do characterize copay accumulator issues as largely a specialty product issue, because for the reasons we just mentioned, they're the ones that are going to create the most ideal targets. But where this rule becomes more problematic or creates another problem is for retail brands, that wouldn't typically be considered high accumulator targets, and that in present time, when we do the analysis, and we still regularly monitor this for all of our copay programs, but our clients that have retail products, we generally will look at their data and tell them, you're not seeing accumulator impact really much, if any, and that's not surprising, because you're not a prime target for this based on your cost. But the problem arises in that whole level of the standard that CMS sets forth with the new rule, in that the manufacturer has to ensure in all cases that the benefit goes only to the patient. Because if you have a retail product, and you may have, in a few isolated exception cases, a few patients that are in plans that are going to do something like this for all products or for all copay assistance, that would then trigger that best price obligation. So where it was previously kind of confined to just a specialty only issue or a specialty only concern, it pretty much now opens the accumulator topic up to all copay programs, just because you have to, as a manufacturer, you have such a high threshold, a high standard that you have to meet and that you're accountable for.
Could you discuss the aspect of non-essential health benefit determinations and its importance as a dynamic in maximizer programs?
I can, yes. So maximizer programs, non-essential health benefits are not required to be counted towards any costs for non-essential health benefits are not required to be counted towards the patient's cost sharing obligation. So that's kind of one of the anchoring principles of how maximizer programs work, is the health plan will declare particular products to be non-essential. And I think we've mentioned before in some of the previous discussions we've done on accumulators and presentations, is the fact that the maximizer programs, you tend to see a lot with self-funded health plans, where they have a lot more flexibility to control and modify benefit design as they see fit. So the way that a maximizer program will operate is that the plan will declare a particular product to be non-essential health benefit, and then therefore any of the costs associated to that do not get credited towards the patient's cost sharing obligation. And then, as I mentioned earlier, what the plan will do is extract the maximum available benefit from the copay assistance offer each time the patient has a claim, the patient will not incur an out-of-pocket expense, and the plan will use the manufacturer assistance funds to reduce their cost. But the patient will still not get credit for any of that cost towards their meeting their deductible. So non-essential classification is essentially, not to use the same term in the wrong way, I just realized that, but non-essential classification makes it that any cost for that product will not count towards the patient's deductible.
Okay. Yeah, because a follow-up to that was, is there a state regulation on who or what determines a non-essential drug, a drug class?
So there is, and it's a complicated topic. We have a few minutes. I'll try to get into the basics of it. It's rooted in each state. So under the ACA, there is the establishment of state benchmark health plans. And within the state benchmark health plan that's essentially how each state establishes what its baseline coverage criteria are. So within that, prescription drugs are broadly classified as an essential health benefit by the ACA. But within that, each state can establish its benchmark health plan out of what's sold on the exchange. And then self-funded plan sponsors can choose which benchmark plan they are using, what state they're using as their benchmark, in order to craft their own benefit design. So that's the broad summary of it, is that a self-funded plan sponsor can pick a state benchmark plan that is most conducive to kind of what it's trying to accomplish. And sort of the analogy that I make often is, a lot of people are probably familiar with a lot of companies are incorporated in Delaware due to the just the nature of the laws there, and how that's ideal for a lot of businesses and what businesses are trying to accomplish. Similar dynamic with state benchmark plans is a business can choose which state it wants to use as its benchmark plan, and then that would define essential health benefits.
Got it. And just one more question I'd like to squeeze in. Do you have any insight into how the rule will affect the medical benefit side of treatments? We've talked mostly about pharma, but do you have any insight on the medical benefit side?
Yes, that's a great question, and it's something I brought up on a previous webinar, and I'm actually glad I got asked. So presently, we don't see as much accumulator activity on the medical benefit side. There was a lot of there were developments toward the end of last year around United Health rolled out a policy that they were set to put into effect at the start of this year that would have required providers on the medical benefit side to report use of copay assistance, patient using copay assistance offers for the purpose of operating these types of accumulator adjustments. That policy ultimately United pulled back. They got a lot of pushback from the provider community around that. And ultimately at the end of the year, they said they were choosing to delay that. So really the way we see accumulator adjustments carried out on the medical benefit side is more through plan self-disclosure requirements, where patients have to disclose that they're using manufacturer assistance. But if or when, and I think there's kind of a prevailing view within the industry that there's probably a decent, another insurer, whether it's United or another insurer, may try try to approach this topic again around accumulators on the medical benefit side. If that were to happen, then this rule would have the same impact. So if a manufacturer coupon is used to offset a patient's cost sharing obligation, but the full benefit of it is not realized by the patient, it would then be required to be factored into best price. So that is absolutely an area that I think manufacturers need to be mindful of with their copay program providers. And another kind of angle to that is, I know we're definitely getting up against time, but another angle to that is we've seen some recent developments in the market around payers shifting coverage for some medical benefit products over to the pharmacy benefit and requiring fill through their specialty pharmacy channels. So really kind of what this represents, I think, at this point on the topic is the fact that we don't have that consistent approach to medical benefit accumulators from the payer side on products covered under the medical benefit. And so that's kind of another way to go about it, is that shifting of coverage over to the pharmacy benefit. And just, again, something to kind of consider, and that we always tell manufacturers to watch for if they have split coverage on their products. But to get back to the root of the question, yes, if accumulators were to become widespread, prevalent on the medical benefit side, the best price impact would be the same under this rule.
Got it. Thank you very much. We are out of time, but Jason, again, as always, thanks so much for a great session and great Q&A. A big thank you to TrialCard for sponsoring today and making this session possible. Just a reminder, folks, the webinar has been recorded. You'll receive an email with a link to the video so that you can view it again. To access additional webinars or get information on how your organization can speak or sponsor, please visit wcwebed.com. Thanks again for joining us, everyone. Have a great day. And this now concludes today's discussion.